Bismillah ar-Rahman ar-Rahim. Rheumatoid arthritis and pulmonary disease. Rheumatoid arthritis is a persistent deforming symmetrical peripheral arthropathy with non-articular manifestations including vasculitis. Pulmonary and pleural disease is commoner in men and occasionally occurs before the development of joint problems of rheumatoid arthritis. Pneumonia is common, causing 15 to 20% of rheumatoid arthritis deaths. The pleuritis, frequent, occurring in more than 30% of patients of rheumatoid arthritis and usually mild. The pleuritic pain with no obvious other cause is the main manifestation of pleuritis of rheumatoid arthritis. The pleural effusion in rheumatoid arthritis, usually asymptomatic, typically exudative with a low glucose, low pH, and a lymphocytosis, and maybe pseudochylous pleural effusion, and often associated with other lung manifestations, and there is need to exclude other causes for effusion, and if problematic, may require drainage and steroids. Pulmonary fibrosis in rheumatoid arthritis, it is similar to idiopathic interstitial pneumonia, minor pulmonary fibrosis found in up to 60% of patients in lung biopsy studies, but significantly symptomatic disease only in 5%. Symptomatic disease is unusual and tends to occur in patients with multi-system disease, including vasculitis and those with nodules, seropositive disease, and the high antinuclear antibody anti-titer, more common in men, and smoking is a risk factor for fibrosis development. Clinical picture of pulmonary fibrosis of rheumatoid arthritis. There is dyspnea, which is progressive, and there is cough, which usually is dry, and examination of patient reveal examination of the patient reveals clubbing and bilateral basal crepitations. The pulmonary function tests will reveal low KCO and restrictive pattern. Radiologically and histologically, usual interstitial pneumonia pattern with subpleural basal reticular pattern, but can be like non-specific interstitial pneumonia. Treatment of pulmonary fibrosis of rheumatoid arthritis. The treatment include antifibrotics and the use of steroids and immunosuppressants, which do little to change the course but should be tried, and the prognosis is much worse than other connective tissue disease, and some study suggests nearly as progressive as idiopathic pulmonary fibrosis. Other manifestations of pulmonary problems in rheumatoid arthritis include acute pneumonitis, which presents with rapidly deteriorating dyspnea and development of respiratory failure, or acute deterioration on the background of chronic fibrosis, and acute pneumonitis tends to be more steroid responsive. Pulmonary nodules. Fewer than 5% of patients with rheumatoid arthritis, and usually found incidentally on imaging, and occur in seropositive disease and are associated with nodules elsewhere, elbows and fingers. Singles or multiple may measure up to 7 cm, mainly subpleural or along interlobular septa, and may cavitate and rarely cause hemoptysis or pneumothorax. Main differentials are lung cancer or vasculitis, usually followed on CT to ensure stability. They typically show mild uptake on positron emission tomography, which is PET scan, and may need biopsy to exclude malignancy. Organizing pneumonia on rheumatoid arthritis, multifocal consolidation with fever, dyspnea, cough, and weight loss, and not responding to antibiotics can be disease or drug induced gold or have no obvious cause, confirmed by transbronchial CT guided biopsy or video assisted thoracoscopic biopsy, which showing a CNI filled with loose connective tissue and a variable inflammatory infiltrate, often dramatic response to steroids, and may need long term immunosuppressants. Small airway disease and obliterative bronchiolitis. Mild small airway disease found in about a third when looked for on HRT, but often symptomatic with variable histology. Obliterative bronchiolitis is a rarer problem with lymphocytic infiltration of the terminal bronchioles progressively obliterated by inflammatory connective tissue. May present with dyspnea, dry cough, and hyperinflated chest with basal crepitations and mild inspiratory crepitations, which is called squick or squack crepitations. Pulmonary function tests revealing irreversible obstructive pattern and hypoxia. The chest X-ray shows hyperinflation but no infiltrates, and HRT there is mosaic pattern. The biopsy shows obstruction of the terminal bronchial wall by granulation tissue, effacement of the lumen, and replacement of the bronchioles by fibrous tissue. Irreversible pathology and unresponsive to treatment and may rapidly progress and can give trial of oral steroids continuing with high dose inhaled steroids if responsive. The penicillamine was thought to be a causative factor, but the evidence for this is weak, and consideration of lung transplant is considered is important. We should consider lung transplant. The vasculitis rarely involves the lung and very rarely causing pulmonary hemorrhage and rare cause of pulmonary hypertension. Other manifestations of pulmonary disease of rheumatoid arthritis include cricoarytenoid arthritis, presents in 75% of patients with rheumatoid arthritis, revealed by fiber optic laryngoscopy and HRST, but rarely symptomatic, commoner in women, unrelated to lung fibrosis, causes sore throat, hoarse voice, and upper airway obstruction with stridor or obstructive sleep apnea, flow volume loop with abnormal, may need continuous positive airway pressure, CPAP, tracheostomy, and steroids, oral and joint injection. The bronchiectasis in rheumatoid arthritis, often subtle with minimal clinical features, but may be found in 30% of cases of rheumatoid arthritis, and diagnosis made on HRST. Sjogren syndrome, causing mucosal drying, often in association with interstitial lung disease, produces dry cough and increased airway infections. Lastly, the Kaplan syndrome, which composed of rheumatoid arthritis, single or multiple chest nodules, and co-workers pneumoconiosis. That's all, and thank you.